Computerized occlusal analysis gives you the control to refine occlusion. In this presentation, you will see an occlusal adjustment on a live patient with the T-Scan 3 system. Robert B. Kirstein received his DMD degree in 1983 and his prosthodontic certificate in 1985, both from Tufts University School of Dental Medicine. Dr. Kirstein maintained an active appointment at Tufts as a clinical professor studying computerized occlusal analysis from 1985 to 1998. He is the leading author and clinician in the field of computerized occlusal analysis and has published articles on the subject since 1989.
The concepts of bilateral simultaneity and immediate posterior disclusion are important and have been around for a long time. With the T-Scan, you have an instrument that can measure these concepts for improved diagnostic data and more accurate and reliable occlusal treatment. The T-Scan measures relative occlusal force and both the occlusion time and the disclusion time. Good morning, Caroline. How are you?
Hi, Dr. Kirstein. I'm good, thank you.
Good to see you.
Good to see you too.
Today, what we're going to do is measure up your occlusion with the T-Scan and see the quality of your occlusion and disclusion. But before we do that, I'd like you to sort of tell me about your symptoms, what you've been feeling, how long you've been having these problems.
It's been well over 10 years that I've been suffering from it. It's basically headaches, jaw pain, you know, the constant popping and cracking, sometimes locking.
And that's on a regular basis, daily, if not
daily,
more than once a day?
Mm-hmm.
And have you had any treatment for this?
I actually had a splint made and wore it for about 6 months. Didn't have any luck with it. Didn't work out so well.
So you didn't find it improved your condition or lessened your symptoms?
No.
Do you take any medication?
I've taken like Advil for the headache and the jaw pain.
Okay. So Caroline, today what we're going to be doing is using the T-Scan technology to measure the time, the elapsed time that it takes you to move left, right, and forward and separate your back teeth. And the longer your back teeth don't disengage, the more muscle firing that your jaw creates for your head. And that's one of the causes of all these symptoms. So with the T-scan technology, we have the ability to measure it very precisely and understand how to change it so that we can shorten that time down to where it's really physiologic for you. So the first thing we have to do is set up a proper dental arch for you, and that involves measuring your central incisor width, which we'll do with this digital caliper. And then we'll choose a proper recording sensitivity for your bite strength, which allows us to record accurate force information. And to do that, we like to have only a few 3 or 4 red or pink cells on the sensor. Okay, so put your head back for me. So I'm going to just measure you with this digital caliper. So I'm measuring both central incisors, and Caroline has a diastema, so I'm going to measure half the diastema as part of her calculation for her central incisor width. I'm going to enter that into her patient file. And to choose a proper sensitivity, Caroline, I'm going to have you bite into the sensor, and I'm going to have you keep your teeth together when you do that. So I want you to bite down for me. Bring all your back teeth together. Try to squeeze your back teeth together. Much better. Do that again for me. Bite down again. Good, like that. And open. Bite down again. Good, and open. Raise the level a little. So we like to see 3 pink cells total to indicate the proper sensitivity. Okay, so now we're going to record your 3 excursions, right, left, and protrusion. So we're going to do the right one first. So I'm going to have you bite down through the sensor, hold your teeth together, and then slide to the right. Okay? Put your head back for me. And each time, before I record, I'm going to have you close fully into the sensor to make sure you're seating your bite correctly. Go ahead and bite down firmly. And open. Bite down again. Now slide to the right. Okay, so now we're going to do one to the left. Head back again. And once again, I'll have you bite once. Go ahead and close fully. Good. Open. Bite down fully. Stay there. Now go left. Okay, Caroline, so now we're going to do sliding straight forward. Head back again. Going to rest this on your teeth again. I'll have you close once firmly. Bite down firmly. Stay there. Now go forward. Good. Very good. Okay, Caroline, let's look at the recordings. This is of you moving to the right, and first, when you close your teeth together, your bite is fairly uniform until the left posterior teeth become extreme, and that happens before the right posterior teeth become extreme. So there's an imbalance in your closure that is predominantly to the left side. You have significant imbalance to the left side. So here, when you're moving to the right, you'll see that your back teeth stay together on the right side and on the left side. And then as you try to move further to the right, you actually have a worsening of the left side. And the T-scan software automatically calculates the time of disclusion, and yours is very prolonged at 3.993 seconds. In optimum occlusion, your back teeth should disengage in fractions of seconds, less than half a second. And that's the kind of thing that we can measure with the T-scan technology that's impossible to see visually by inspection, visual inspection. And so here, a goal would be to have your back teeth separated in less than half a second, and you're dragging your back teeth together for a very long period of time. Actually, when you move to the right, your back left gets in the way and stays in the way during the entire movement. So let's take a look at going to the left. And the left one is actually the reverse of the right one, because you have the same dilemma. When you move left, your right side stays together. So going either direction, you do not disengage your back teeth in less than half a second. And so this is what keeps your muscles active. And an optimum goal of occlusal therapy would be to reduce your time of disclusion down to less than half a second. That's an optimum physiologic health goal. And you can see it takes you never get off this tooth. You're consistently on this tooth. And in protrusion, your function is better. meaning that you separate your back teeth better than when you come to the right or to the left. So when you slide forward, you have less back tooth engagement. Your back teeth are slowly leaving the screen as you bring your jaw forward. And you tend to separate better in the back coming forward than you do when you are sliding right and left. Does that seem clear to you?
Yes, now looking at the screen I can see why I have the muscle pain.
Very good. So now I'm going to mark your teeth with the articulating paper so we can locate where the long disclusion contacts are present on your teeth. So put your head back for me. I'm just going to dry your teeth. Now I'm going to place the articulating paper in between your teeth. I want you to bite down for me. Slide to the right. Go further. And back. And to the left. Try to go further. Good. Now slide back to the right. Try to go further. Good. And back. And to the left. And open. She has group function going to the right on this bicuspid, and on this bicuspid, and on this molar. And so these are the contacts that are on the lower teeth that are making up the long disclusion. The most critical one is this one here. It's on the distal buccal incline of the occlusal surface of the second molar. On the opposing teeth, you can see the balancing inclines present on the second molar and on the first molar, both on the mesial and the distal. There's group function contacts coming towards the buccal on both premolars and on the lingual of the second premolar. To mark the left side, insert the articulating paper after drying the teeth well. Have the patient intercuspate, slide to their right and to their left, back into their intercuspal position, then to the right and to the left again. On the left side, you have working side group function on the two bicuspids and on the first molar, and balancing incline on the second molar. On the lower teeth that contact those same upper teeth, you see cheek side group function on all the molars and the two bicuspids, and you see the guidance could be on the canine if there was less posterior tooth contact in the way, and there's also the balancing incline on the distal buccal aspect of the second molar. To reduce the disclusion time, it's necessary to treat the inner inclines of both the premolars and the molars where you see the linear articulating paper markings. Here you can see I'm working on the mesial aspect of the first molar and the central fossa of the second premolar. Here I'm working on the inner aspect of the second premolar and the inner aspect of the first molar on the buccal incline, removing that line that goes out towards the buccal from the central fossa. And here I'm reducing the size of the lines around the central fossa and the mesial marginal ridge on the first premolar and second premolar. Now I'll move to the balancing incline on the inner aspect of the upper left second molar, try to shallow that incline so that the lower tooth misses it as it passes by when the patient moves to the right. And this is a key area in this patient's treatment. And here I'm just refining these initial markings. On the opposing lower teeth, there's contacts that make up the long disclusion on the buccal aspect of all the posterior teeth. Here you see I'm working on the premolars, now the distal aspect of the first molar. And what I'm doing is I'm trying to remove the contacts that are down on the buccal surface and shave the cusp back to eliminate the friction that's there and taper the shape of the tooth to the contact that's at the cusp tip. Here you see I'm refining the second premolar and then again the buccal aspects of the two molars. And now I'm going to treat the balancing incline on the distal buccal cusp of the lower second molar. Leaving the teeth with the dust from the adjusting on them, you can remark the teeth with the articulating paper by having the patient intercuspate again, slide to the left, slide to the right, back into their MIP, back to the left, back to the right, and once again into their MIP. After marking the teeth for the second time, you can see there are still contacts down on the buccal surface of the premolars, which will prolong the disclusion time. The molars appear to be fairly clean, although they could be touched up a little bit. You don't see much surface contact. Here I am trimming around this central fossil contact on the lower first molar, and also the balancing incline again on the lower second molar, and once again on the buccal aspect of the premolars, trying to bring these contacts to be very small in size with very little inconsistent markings around them, all of those markings being removed. The counter adjustment on the upper arch, again refining the markings that are in and around the central fossa and marginal ridge. You see I'm leaving the contacts that are in the central fossa on the first premolar. I'm trimming around that mark. I'm trimming around the cusp of the upper second premolar, and each tooth I'm looking to make the marks almost not surrounded by any slightly inconsistent marks, no scratch-like marks. That's what I'm doing here. I'm just touching the teeth, removing small lace-like marks that the T-scan shows to be long disclusion time. And for some of you that may be an adjustment in your own thought process, because a lot of the marks that we're treating are very small, lace-like, and scratch-like. After remarking the teeth in the same fashion as before, with the patient sliding in both directions from their MIP, I'm now trying to remove the last little bits of friction, any kind of drag that we see on the teeth, any linear contacts. And notice that I'm just sort of lightly touching the teeth with the burr, cleaning up around the contacts that I wish to keep. You can see two of them in the central fossa of the first premolar and second premolar. The counter adjustment on the lower left, you see there's a line of contact all along the buccal cusp, but there's also still some contact down on the buccal aspects of these cusps. And you can see I'm trimming around the cusp tip of the first premolar, down on the buccal cusp of the second premolar, trying to move any linear component back up towards the cusp tip. The two molars have pretty good line of contact, just touching up the buccal surface and any scratchy little lines, inconsistent contacts. Here I'm moving a contact that's down on the buccal surface that indicates long disclusion, and a little touch up to the balancing incline on the distal buccal aspect of the second molar. After completing the shortening of the disclusion time on the left, we repeat the process on the posterior right. Here you can see I'm removing linear components to any of the contacts in and around the central fossa, down on the buccal surface. As before on the left, way down below the cusp tip, all of those contacts get tapered up to the cusp tip. And you can see I'm doing that here on the second molar and the mesiobuccal aspect of the third molar, and now the first molar, trying to move the linear components back towards the cusp tip or into the central fossa. Now I'm treating the second premolar, trimming around the cusp tip and working the contact closer to the cusp tip only. On the opposing upper right side, here you see contact in the central fossa on most of the teeth, and slight contact, scratchy little lines, and inconsistent contacts all around the contacts that are desirable in the central fossa on the marginal ridge. A good example is here on the buccal aspect of the first molar. I'm leaving the contact in the marginal ridge area, but treating the buccal aspect of the first molar, and doing the same thing here on the buccal aspect of the upper second molar. Also refining a little bit on the lingual, just gently touching the teeth, removing any of the lace-like contacts. Okay, Carolyn, we're going to re-record now going right, left, and forward. Okay, put your head back. This will be to the right. Go ahead and bite down again. There we go. Open, bite down again. Now go to the right. Good. Excellent. Okay, this time you're going to go to the left. Go ahead and bite down. Good. Open. Bite down again. Stay there. Now go left. Good. So now, Caroline, when you close, you're much more balanced. You're a little more right-sided than absolutely perfectly balanced, but you're much more centered with your center of force. It doesn't travel way off to one side, which is a significant improvement, and the total center of force is more forward and within the middle of occlusion. When you slide to the right, your right side stays in play a little bit longer than I would like. It separates much better, but there's still a little bit of drag on your right side, so I'm going to have to go back and work on that. You can see that your middle and your middle of your right side stays together, and that we want to kind of improve. Right now your disclusion time is 0.687 seconds, which is a lot shorter than it was pre-treatment. Pre-treatment it was much longer than that. So your center of force is now more balanced and you disclude much faster going to the right. Let's look at the left. On the left, you see the same kind of slightly right-sided center of force, although it comes right to the middle, or almost the middle, which is good, overall balance when you close. Now when you slide going left, this is a significant improvement over pre-treatment. Now your both sides disengage. You have a little bit of drag on the left side, not too much. Total time 0.3 of a second. So that's actually an ideal endpoint, less than 0.4 of a second. So the left side is pretty good, as I would like it to be. The right side needs an improvement. And let's see about the protrusive movement. In protrusion, you reach your front teeth very fast. You're going forward, much more separation of your back teeth. This is the sensor folding up in the back. So that's not real contact. So you reach your front teeth extremely well, almost in no time. Let me see. 0.3 of a second again. So the only movement that has to be touched up is going to the right. So Carolyn, now that we've straightened out your occlusion, what's different about it? How does it feel different than from before we treated you?
It feels a lot different. It feels good. Definitely align better. I can feel it in the back, less pressure.
So it feels lighter in back?
Yes.
And does it feel like you can close and your teeth fit together?
Yes.
Yes. And did it feel like that before we did this?
No.
So that's one of the advantages of disclusion time reduction. It automatically balances the bite and closure for the patient. Speeds up the process of doing occlusal adjustment therapy. So now I need you to return in 1 week so I can remeasure all the changes and make sure that your occlusion is optimal, and we'll actually do very much like what we did in the second part of the procedure where I measured you and I made subtle corrections to small problem contacts that are left there. So for the week, you just go about your business. You don't have to wear your splint. You don't have to take any medication unless you need it, and try to eat normally and come back in 7 days and we'll remeasure you.
Great, thank you very much.
Thanks. So now that you've come back after a week, I'm going to remeasure you just as we did before to check your occlusion and your disclusion and do any subtle corrections to make it optimal.
Okay.
I'm going to have you bite down on the sensor again, but I just want to make sure that we have a good recording level for you again. You've been away for a week, so just close firmly and open for me, and close firmly again, and good, open, bite down again. Now slide to the right, and good. Go ahead and bite down once for me. Good. Open. Bite down again. Now go left. Good. Very good. Okay, this time you're going to bite down and slide forward again. Okay, bite down once for me. Good. Open. Bite down firmly. And now go straight forward. Keep going. Good. So, Caroline, in looking at the data after a week, there's been the development of some anterior pressure. You can see that here, that your front teeth are becoming more forceful before the back teeth start to get into contact. So I'm going to need to relieve that. However, your center of force is still very stable. It hugs the midline, comes straight back to the middle of your occlusion, and that's a really good sign for positive closure and balance in your bite. So the front teeth I have to lessen a shade. The COF, the center of force, it starts a little too far forward and it kind of moves outward and then moves backwards, and that indicates anterior pressure. And then in one of the movements, let me see, to the right, I believe, we have a little bit too much tooth contact when you move to the right again on the left side, which has been a battle with you to try to get those last few teeth to separate. So there's a little bit of drag in the posterior right and the posterior left, but not too bad, quite good separation overall. And the disclusion time is 0.4 of a second, which is good, and it is in the optimal zone of less than half a second, which is what we shoot for in terms of therapeutic end result. So even with that, there's still a little bit of friction and drag on a couple of the back teeth, more on the left than on the right as you go to the right. And so just a few minor touch-ups we need to do in order to optimize this end result. So I will dry the teeth again, but this time have the patient self-intercuspate without sliding in any direction in order to mark the lower anterior teeth and the upper anterior teeth where there is too much anterior pressure. The contacts that create the pressure are generally down on the facial aspect of the incisal edge, and you can see all the series of marks that make up this excessive anterior pressure. Here I'm going to plane back the incisal edge, not shorten the tooth, but cant the facial aspect of the incisal edge towards the incisal lingual so that there is still contact but less surface engagement of the lower anterior teeth against the back of the upper anterior teeth. So we will remark the teeth in the patient's habitual closure in order to assess the remaining amount of surface engagement after one adjustment. You can see there's definitively less surface engagement, and I'll refine it some, looking for small contact points and lace-like marks that will be near the contacts that are desirable. You see I'm planing the edges back at an angle. And then for patient comfort, it's important to polish the incisal edges and smooth away any graininess. And these rubber wheels do an excellent job of smoothing enamel or porcelain. You can see I'm lightly dusting the edges and polishing back towards the incisal. So here I'll air dry the teeth again and place the paper on the patient's left side and have them repeatedly move to the right as I try to locate the contacts on the upper and lower left that are prolonging the disclusion. So here you can see on tooth number 15 in the mirror view, on the distal palatal incline towards the occlusal surface and on the mesiopalatal incline towards the occlusal surface, there's linear markings that are lace-like and scratch-like. Those are representative of the fractions of seconds that prolong the disclusion when the patient moves to the right. Here on the mesiopalatal aspect of the upper first molar on the left side, you can see some of the long disclusion present with the linear marking that's emanating from the slope up to the cusp tip. Now I'm going to adjust that area. You can see I've taken the burr and lightly I'm dusting the cuspal incline, removing that mark in its entirety as that's a balancing interference. After remarking the teeth to check our first adjustment, you can see there's still long disclusion present on the mesial aspect of the first molar and some on the distal aspect of the second premolar. So here I'm going to refine those even further and eliminate those markings. Now when we mark the right side in the right excursion, we're looking at the mesial aspect of the first premolar. There's some friction and drag, and you can see this linear mark on the palatal aspect of the second premolar. That definitely demonstrates long disclusion. And then back here towards the buccal aspect of the second molar, heading towards the buccal cusp. That's where the long disclusion is present. Here I'm refining the linear aspect of the second premolar, the mesial aspect of the first premolar, removing the friction and drag. Now I'll move to the distal buccal aspect of the upper second molar to remove the friction and drag there. Be careful not to shorten the cusp tip, as that can induce cheek biting. So we made those subtle corrections, so I want to remeasure and make sure we improve the situation slightly. So I'm going to have you bite down and slide to the right again. So bite down once for me. Good, open. Bite down again, firmly. Now go to the right. In order to compare the before and after right or left excursions to each other, you need to look at how far into the excursion preoperatively compares to when the person discludes postoperatively. So here in movie 0.408. The timeline is to the right of C in the graph, 0.428 seconds, which is the actual postoperative disclusion time. What you can see in the two-dimensional plot above the graph is that there's posterior teeth in contact on the screen. Tooth number 15, number 14, number 2, number 3, number 4, and some of number 5 are all in contact after the patient has moved to the right only 0.428 seconds in the preoperative condition. Postoperatively, after the patient has moved 0.428 seconds into the excursion, there's no posterior tooth contact behind the canines. And this is the difference that's been performed therapeutically for the patient by doing the adjustments we did based on the disclusion time. The pre-treatment disclusion time of the right excursion was 3.993 seconds, and now it's 0.428 seconds. And that is the measurement that is the difference in the patient's therapeutic treatment. The same comparison can be made for the left excursion. Pre-treatment, the disclusion time was 4.925 seconds, and post-treatment, the disclusion time is 0.363 seconds. If we place the timeline in the preoperative graph of movie number 9, 3.63 seconds to the right of the C line, we can compare the amount of tooth contact that's present in both excursions after 0.363 seconds. In the two-dimensional plot above the graph of movie number 9, you can see that tooth number 15, 14, and 12 and tooth number 2 are still in contact after 0.363 seconds has passed. Whereas postoperatively, after 0.363 seconds has passed, there's no posterior teeth in contact at all. Well, thank you for coming in for your follow-up. As you can see, with the T-scan technology, we have the ability to find, minutia within someone's occlusion and make subtle corrections that can make a huge difference for their physiology. So measuring the disclusion time and the balance in your occlusion, we've rearranged it all, and it was only possible because of computer analysis with the T-scan. So thank you for your help, and I'll look forward to seeing you in the future.
Thank you.
TechScan, manufacturer of the T-Scan occlusal analysis system, offers various training courses held throughout the country by the leading experts on occlusion. You You can view our upcoming event schedule at www.techscan.com and click on our dental page for a course near you.